one technical meeting. So today is a very important topic. We all come across as clinicians working here, ICQ, insertion and maintenance of ICQ, and also when to remove and all. So it is very important, indications and all. So today, the lecture will be done by two thoracic surgical senior registrars, Dr. Dilip Padanayak, and Dr. Welisara, and they will be joined by the expert panel, Dr. Hadagala and Dr. Sujiv will join as an expert panel. So I will invite Dr. Hadagala to do the lecture first.
Good afternoon, everyone. So I'll be discussing a bit about intercostal drain, insertion, and Dr. Hadagala will discuss the management part basically. So I'll touch upon the introduction and the principles of underwater seal drainage system and the component and types of chest drain that we use frequently, and indications and the procedure, a little bit of the procedure and the complications of things. So intercostal drainage is a way that we drain whatever the collected fluid or air inside the pleural cavity by means of a tube out of the cavity. So it's not like something like draining fluid in the body, because this has a very important physiology, because there's negative pressure usually inside the pleural cavity. So that's why this should be done in a one-way mechanism. So whatever the content that we drain should not be returned back to the pleural cavity during the negative pressure period of the breathing. So that's why we do it as an underwater seal mechanism to prevent this going back of this fluid or whatever the content that we drain during the procedure. So the principle is, so our aim is to remove whatever the content, that is either it could be already collected content, or it could be a possible the collectible content, that's in like we insert drains after post-operatively, all those things. So to drain whatever the possible collection. So the bottle system comes up, the main important part is we insert tube inside into the pleural cavity, and we keep it, the tip of the tube is kept under water column, usually about 2 centimeters. So to help me demonstrate this, the tube submerged at least 2 centimeters inside water column. That is to prevent the entering of whatever the outside content into the pleural cavity. So, but you can understand that when we submerge it inside water, so there will be pressure of 2 water centimeters at the tip of the this IC tube connect. So then the patient or whatever will have to or counter this resistance. So that is achieved by the gravity mainly. That's why we keep always the bottle under below the patient's chest level, and the positive expiratory pressure. Usually in so when we insert an IC tube, usually we insert it for some indications such as the pneumothorax or hemothorax. Usually in those conditions, the intrapleural pressure actually becomes positive. So usually it is negative, but you know when there's something, when there's some content inside, so it becomes positive. So this drainage procedure occurs because of this gravity as well as by the positive expiratory pressure. So if we don't keep this negative the water column, so what will happen is during the inspiration, when the intrapleural pressure becomes negative, so they will just go in, and there won't be any effect of the tube. So there are that is the actual basic principle of the passive drain that we use commonly. So what there are active drainage system, like this is an active commercially available active drainage system. That means in the active drainage system we artificially create a negative pressure outside. So thereby we drain whatever the content that is inside the pleural cavity. So we also have some negative pressure systems in our unit, and there are some commercially available portable like system. This is also one of those things. So the pressure varies depending on the course that we apply negative pressure. Usually it's about 3 to 5 kilopascal, the negative pressure, -3 to 5. So It is what I just mentioned. So the water column, sometimes actually I have seen people connecting this tube to the other port. Actually, that port is there to exhale the gas that is collected inside the bottle. So make sure that always this patient's tube connected to the underwater seal tube. So that's where we can achieve the proper underwater sealing system. So the other tube should be kept open to the outside to remove the gas that is collected inside the bottle system. So we have different types of bottle. This bottle is I have shown is the one that we use commonly here. It's a two bottle system. So that is again the two bottle system is because so when there's some collection inside the underwater seal bottle, so we can remove that part into the other bottle because when there's a lot of fluid accumulated, the patient needs more expiratory pressure to exhale the remaining content. So when the water column goes up, so the tip of the pressure at the tip of the tube goes up. So we need to always keep in mind that when the bottle gets filled, so you can actually empty it into the other side and maintain the adequate pressure. So this is what happens during the inspiration and expiration when there's an intercostal tube. So during expiration, so the interpleural pressure becomes positive, and whatever the content that will be pushed out into the bottle. So air will just they go out through the opening, and the water or the fluid will get connected. During the inspiration, when the interpleural pressure becomes negative, so this water column will go up to the level of the interpleural pressure. So, but it won't go back to because there will be significant gravitational effect with the height of the bottle and the patient. So this water column will go up, but there won't be any air going in because of the water column. So it will prevent accumulation of air or developing a pneumothorax. So there are different types of drainage system. I'll be just discussing about insertion of the conventional IC tube system. But there are now, a lot of, except for other than for the conventional IC tube system, we have Seldinger type you all are familiar with, and pigtail catheters for some indications we insert actually pigtail, not just IC tube, and even Foley catheters can be inserted. It is again same thing like this Seldinger type IC drain, and then intrapleural catheters. We don't have it here, but it's a very good thing for this malignant diffusion. And pleural vent also, we have inserted few here. That's also good for the recurrent pneumothorax. And when you can't discharge the patient with the bottle, so you can just send them away with the pleural vent. So this is the basic component of the conventional that we underwater seal IC tube drainage system. So we have a test tube, and there are different type of test tube. The right side one is actually this one with the trocar, but we don't use it much. And the other ones are the other tubes that we use. There are curved tubes as well as the straight tube. So the tube is also there's numbering. So there are 6 holes, and the numbering starts from the last hole. The last hole in the means from the not the at the tip, from the proximal last hole, and it will be numbered from by 2 centimeter, like 2, 4, 6, like that. And the last hole is usually at the radio pack line. So when you insert an IC tube and when you take an X-ray, so you can see the last hole and you can confirm that the holes are inside the pleural cavity. So if there's one hole outside, then you can detect it because the last hole is usually at this radio pack on this radio pack line. And sometimes we actually during surgeries we make few additional holes. So at that point also, even if you are going to make few additional holes, make sure that you make the last hole on the radio back line. Otherwise, you can't make sure where the last hole is when you insert it and take an X-ray, especially in an obese patient. Sometimes you might keep a lot of significant length inside the fat layer. So these are different type of bottle system, single bottle system, and then the middle one is that the one that we use, and the pediatric bottle, and the other one is actually 3 bottle system. So there are different type of bottles. So these different type of ports. So apply the application of suctioning. Actually, we can apply suction to all these bottles with the other opening available. That's right. So with these all these bottles come with tap here to this outside opening, but make sure that when you insert an ICT, always remove that. Because sometimes we keep, some people keep that there, then there will be again positive pressure developing inside, so the air won't go out. If you keep that cap on the that this vent out the exhaling vent. These are holding a drainage system. So it you can insert it via ultrasound guidance. So sometimes even we can after pre-marking also you can insert. So it comes with a set. It's like holding a decking means you can just like inserting the central venous line, same principle. And pigtail catheters also for like isolated collection abscesses, loculated effusions, loculated means single loculated effusions. So you can insert pigtail catheters ultrasound guide. But that would good. It's not a good option for abscesses because usually when the pus is thick, so these tubes are too small to drain thick pus. So it's good for simple like fluid collection, but not good for actually for the thick pus collection. Then intramural catheter, that is it is actually the best management kind of thing for recurrent pleural effusion, especially in malignant pleural effusions, but it's currently not available in Sri Lanka. And the importance of visit patient, it has a one-way valve, so patient can actually go. We can send the patient home with the system. Patient can himself by get empty the bottle and get used to it. So they can just keep it there and do their normal work. This is a pleural vent. We have used few pleural vents even in our patients. So that's good for again recurrent pneumothorax patients. So it's very easy for them to manage. It again has a one-way valve and a diaphragm. So whatever they are collected inside will drain, but there won't be any reaccumulation. So this is some of our patients. And indications, there are thousands of indications. So in emergency setting, most of them it is usually the pneumothorax. So it could be spontaneous pneumothorax or even traumatic conditions. So there are some rules like the size of the pneumothorax, like if it is more than 50% of the lung collapse, so if the gap of the chest wall and the lung is more than 2 centimeter, that again you have to make sure that it is in a standard chest X-ray, not a small, because the chest X-ray comes in different sizes. So if it is a big or small chest X-ray, then you have to make sure that the size matters actually. The 2 centimeter should be in a standard chest X-ray. And the posterior anterior, in the second intercostal space, if the gap is more than 2 centimeter, so then there's an indication. And if the patient needs mechanical ventilation, even if the pneumothorax is very small, you usually, because otherwise you can't ventilate the patient, then there's an indication. And tension pneumothorax, so tension pneumothorax, you all know, we don't wait for the IC tube insertion, you just empty it by just a needle thoracostomy, either the second intercostal space mid-intercostal line, or even you can actually now they recommend to do it at the lateral, the safe triangle area. And in any unstable patient, and if the patient is, if we plan to transfer the patient, especially air transport. So in those situations, even if the irrespective of the size of the pneumothorax, we have to insert IC tube in those situations. Then in traumatic sessions, most of the time, sometimes even without imaging, if the patient is clinically unstable, so when we suspect blunt trauma with significant thoracic injuries, we insert. So we don't wait for X-rays or even scans. We just on the clinical ground we insert. Sometimes prophylactic bilateral IC tube also we insert, but that depends on the setting. So elective settings like for by pleural effusion, different type of effusions we get, and then for pleural disease. For any malignant situation, no or recurrent effusion, no pneumothorax, and then the chylothorax due to either damage to the thoracic duct or any of those situations. And there are some other post-operative prophylactic like we insert after thoracotomies, CABGs, and even after esophageectomies, if we have done thoracic mobilization, though it's not like the respiratory or cardiovascular wise condition, so we insert IC tubes just to drain whatever the collection. And even if there's an anastomotic leak, so we can detect it with the drain. There are some contraindications, although they say there are no absolute contraindications. So if there are dense adhesions at the site of the insertion, you don't usually insert IC tube because there's a high chance that you might damage the tube and you will insert the tube into the parenchyma. And in a case of for traumatic settings, if the patient needs an emergency thoracotomy, you don't wait and waste time by inserting an IC tube. You need to do the thoracotomy in those patients. So, and there are some relative contraindications such as coagulopathy, emphysema, the bullae, and loculated diffusions, and patients with diaphragmatic hernia, and hepatic hydrothorax. That's also another condition where recently also we got confirmation. So with CLCD, they get recurrent pleural effusion. So the recommendation is actually not to go for IC tubes. They should be managed with repeated aspiration. So if you insert IC tube, you won't be able to remove it. So that's the problem. So they don't recommend to insert IC tube. So theoretic or even sometimes for this because their physiology is different. The reason for fluid accumulation cannot be alleviated by just by an IC tube. So I'll just discuss about the procedure. So these are the instruments that we need. It is basically you need to remember that it's an external procedure. You need external gowns, gloves, and antiseptic solutions, then grapes, and the local anesthetics, syringes, those things, scalpel, number 23 or number 11 blade, and suture. We use one nylon sutures, and then a robot forceps, that's a blunt tip forceps, and the size of the correct size of the test tube depending on again the indication. So for pneumothorax, actually we can use the small tubes such as 20, even 24 might be adequate. But if it is a large emphysema or pneumothorax, you might have to even use 28, 32 like tube, and connecting tubing system and drainage system, all these things. So make sure that you keep all these things prepared before you go and make the incision on the patient, because otherwise you might just make the incision and put your finger in, and then only you will look for the tube and the underwater seal and the water and everything. Then the assistant nurse also will just walk here and there to find out these things, because you should have prepared everything before you insert, you make the incision. So procedure, you have to explain the procedure. Usually we do it as a just board procedure under local anesthesia. Though we do it under local anesthesia, it's quite painful because sometimes you go and you might actually touch the periosteum, so it's very painful. You don't completely anesthetize the periosteum when you touch the ribs, and so you explain them and take the consent and different positions. So I'll discuss in a while, and again reconfirm when you go to insert an IC tube, the imaging and the site, all these things again reconfirm before you insert an IC tube. So, and local anesthetic, we usually use plain film again, even with adrenaline, and just short acting ones, even long acting ones, something like bupivacaine can be used. So it will give few hours of pain relief even after the procedure. And intercostal block, if you can give it, usually will be seen as inpatient. So you can block actually the relevant intercostal space, and one space above and one space below. So that will give actually good pain relief if you give an intercostal block rather than just giving a field block. So patient position, there are different positionings such as this. Usually we insert it in the first position, that is we call the sunbaking position, like 45 to 30-degree angle, and the patient should keep his arm below the head. And in the seated position also we can insert, and then the lateral position, just as like we do surgeries. And the skin incision again, the safe triangle you all know, so we learn it from undergraduate days. But now they say the safe triangle, the margins, they say it's anterior in the pectoral, lateral border of the pec major, and inferior the fifth intercostal space, and the posteriorly the lateral edge of the lower muscle. But now even they recommend actually it should be inserted anterior to the mid-axis line, because there's a chance that you might damage the long thoracic nerve if you go more posterior. So fifth intercostal space is because diaphragm might come up to the fifth intercostal space level. So anteriorly, if you go more anteriorly, you might go through the pec major muscle, and so you might damage two nerves, and then it will be painful for the patient. So going through a large muscle. So, and we make the incision, but there is the size of the incision. Actually, you should be able to accumulate your finger, one thing. And then because you can't make a very small incision and just try to insert, because you may not be able to accumulate your finger to feel the space. And then you go with blunt dissection using an artery faucet or the robot faucet. And after placing the IC tube, and the earlier they used to say that if it is a pneumothorax, so you keep the IC tip of the IC tube in the apex, and if it is a pneumothorax or something like that, you keep the tip in the base. But you can't make sure when you insert it in a small hole, you don't know where it's going. So it's actually it doesn't matter. So wherever you keep, so the physiology, you know the principle. So the grading doesn't happen because it is the depending on the part of the tip wherever it is. So it will grade because of the pressure gradient. And after insertion, so you make sure that you correctly identify the skin level, and then put a securing suture. We apply usually two sutures. One, not the typical pursing suture. We apply just a vertical metric suture and keep it for to close the wound when we remove the IC tube. So usually some people apply, but the pursing stitches are not recommended. And after inserting, and you have to make sure that tube is functioning. So by observing the swinging of the water column. If there's massive drainage, again you may have to control release, because to prevent re-expansion edema, pulmonary edema. So initially they recommend again to remove 1 to 1.5 liters, and then gradually remove like about 100 to 200 milliliters per hour. So this is again what I just discussed. You go just above the upper border of the rib, the particular space, and he has just demonstrated in this diagram. We make the skill incision a little below the particular rib that we are planning to go in. So there will be a small skin flap, skin and subcutaneous flap, so that when we remove the tube, so this will get automatically closed. So there won't be just direct fall into the pleural space. That's why we usually make the incision a little below, and we go from the above intercostal space, and just over the upper border, so that you may not damage the neurovascular bundle. And then you insert a finger, and then you feel the pleural space, and if the lung is adhered, you can just see fit away with the finger and make this space. So as mentioned, the demonstrated in this diagram is the basic way of that we insert an IC tube. And the post procedure, immediately documentation is very important. One thing you need to document the procedure, what you have done, the insertion of what site, and the local anesthetics used, and the skin level, because if the tube has come out, then you know that it has come out. Otherwise, somebody might later not know at what level you kept the tube inside. And the post procedure instruction very clearly, you should keep them on good analgesic, because it's a painful procedure. And if there's any special monitoring needed, such as if there's massive effusion, and how to release and when to clamp, and those things should be mentioned, and the post procedure test X-ray. And all these instructions should be documented clearly. That's very important, because the management of the tube might be done by some other people, not the one who has done the procedure. Complication, again, there are thousands of complications. Damage to local structures such as lung, liver, spleen, heart, diaphragm, all these things have been reported. Great vessels and nerve injuries, phrenic nerve, long thoracic nerve, and malposition, again the placement inside the fissure, inside lung parenchyma. Sometimes we insert it to the abdominal placement, and dislodgement. Then other like complications, not actually complications, are the adverse events are such as pain. The patient might actually develop hemothorax after insertion. It will damage the neurovascular bundle, pneumothorax, emphysema, and fistula. All these things are there. So the management of these things will be discussed by Dr. Hosander. So question actually we keep it towards the end. And in summary, so basically we have to select the correct patient and select the correct type of drainage procedure, because not every patient require an IC tube, and it's not an easy thing to have an IC tube, and so you need to identify the indication and clearly and select the correct procedure or correct method of drainage to the particular patient. And before inserting, always make sure that you have all the instrument available and the monitoring things and all these things, and proper documentation of the procedure, and observe for complication and if there's any early detection and intervention. So that you can prevent most of these adverse. These are my answers. Thank you. So Dr. will discuss the management part.
Very good thing. And until also the expecting, three things are very far. Please hands up those who have inserted ICT, at least one. So I know a lot of doctors now, our SRs might go abroad for UK. So he mentioned certain things that we need to collect. We don't have a bit about product otherwise you nurse about that you build the article most people can decide for if you are trying to do that those gadgets are in different cupboards. You have to locate everything among the only in assistant keyboard so you have to find stitch you know when locker cupboard there different cupboards. The rooms are locker different access codes. It's a real hustle. So we have to know the things that you need to put at you first. But it's a blending you need to be very prepared. And the other thing that he mentioned about safe triangle noises. Better to go with the safe triangle. But all other times, especially for located diffusion, you need to do under ultrasound guidance. There was an ultrasound workshop. Echo Karla you get it marked by a radiology. Then you can go even below the fixed intercostal space. Which is safe triangle again unknown. The other thing. And but if they go on resource may bottle part of tip but at least out there, Pahal may tip may Sudipart may captain a may bottle open take a CN when I Sudipart tip. Someone but in Abuga, summer icy bottle make a body netting connector may handle it. One a couple I create because you don't keep people, right? So, a bit of transfer that follow out the it take a ultimately getting unexpanding them, but then much transfer. So, this is the main code. Fortunately, some are manufacturers over loose to one over them, 100% blocked in but it may not function fully. It's a Hamilton over the low suction connection to the hand. You cannot have maybe open the button over the Mahindra transfer like hospital, advantage, and make it our game with the papa. What is I come I broke a item of Yaku or Angela Angela Hamokama down the back. Matalamek of Swag and Dress. Samarum get the wasn't Samarunge and down the back, you can't read the ribcage with the finger just because you are so fat. Him idea are a proca tube bigger, what you know. But proca tube that the Happy Hospital, that has to be done very carefully. Proca tube down on a normal Mangarani, the normal hypodermic needle, Digamaki, ribcage reach that. So, local plus a cutting in the intercostal space injector. That injector, so when you put the trocar tube, we have to we have to guard with the other hand, non-dominant hand. We have a guard got bastard behind me. You won't get a sort of uncontrolled, push up in a heart lung. So So we have to guard. Robots එක පාවිච්චි කරනවා මම මේගොල්ලන්ට කියන්නේ you have to guard with the non-dominant hand and මෙහෙම කර කර තමයි යන්න ඕනේ with the guarding hands on the non-dominant hand. That is very important. Okay, no, this practical point.
One case is that if we can get you to ultrasound, that is very important.
Yeah.
In that case, because you have the basic skills and you can measure the depth of the fluid also. And then you can guide the profile to that measurement.
Exactly. Yeah.
That's why we need the ultrasound, but we will do another workshop for our people also, like
That's
right.
ඒක බොහොම කාලෙකට යනකොට දැන් අපි දන්න අපේ රෙගියුලර් ලෝඩ් එකේ ටෙලස්කෝප් එකක් හැවුවොත් එන්නේ හරි ලාර්ජ් එකකට වෙන ස්ටැට් එකකුත් නැහැ ගොඩක් වෙනස්. ස්ටැට් එකට වඩා ඉම්පෝටන්ට් වෙන්නේ අත්‍තරම අල්ට්‍රාසවුන්ඩ් has bedside nowadays. I know pulmonologists they need the telescopes, but we need to be very conversant with ultrasound at least to detect fluid. Yeah.
And this one question, like, then size matters.
Yeah, size
It's
matter
very
that
fine.
is set, you know, for empyema, if the tube is thinner, 20 will do it for early empyema. But stage 1, 2 වගේ train way, you know, stage 3 වගේ අර ලොකු මකි.
Earlier there were some studies like there were no different size.
Even
But
BTS
later
says
on, now they have accepted the larger size.
larger size will train much, but larger size will be more discomfort to the patient. The small early empyema, so in effusions, even size 8, 12 or body pigtail not cut කරයි. But for empyemas, I would go at least 20 setting got down.
We have only 8 weeks and
18, 20 range.
Thank you very much, sir. Good afternoon, everyone. I'm Mosadar. So, after Dilip's wonderful presentation, I would like to continue with the management. Now, this presentation would be a bit different. There's no formal presentation, but I would like to discuss few questions. Frequently asked questions by me, but you guys ask me to do. Often we get, what do I do next? So I collected some questions that has been asked by me, and we'll try to get the answers from the expert panel as well. So yeah, now this one also, so the Dr. Dilip Daj, IC tube is inside. Now you have got the IC tube in, what to do? Yeah, this thing, although not mentioned in this, is talk to your patient. Because patient will tell you a lot of things. After the discomfort of either pneumothorax or a hemothorax or a collection, if you talk to the patient, he will definitely say, I'm better or not, and ask for whether there's a pain. There can be shoulder tip pain, there can be abdominal pain. So talking to the patient is very important. Then again, take a chest X-ray, see the repositioning. Sometimes the eyes have come out, sometimes the tube is malpositioned, sometimes the tube has not gone into the chest cavity. It's in the abdominal thoracic wall. Believe me, that happens. So take a chest X-ray and measure the drainage. I will tell you why. And give some analgesics, antibiotics, and please mobilize the patient. Try to mobilize the patient. We see a lot of, like, from outside not happening in the NHRD because doctors here are very educated, so should give the credit to them. Sometimes after ICU, patients are in bed. He's catheterized, he's having. So I think unnecessary. So try to get your patient out of the bed, have him mobilized, encourage him to cough, encourage him to walk around because there's a large area in this hospital. Important. So in order to mobilize, you have to get the other things correct, especially the analgesics. Patient who is not pain managed will not mobilize, will not work. So be judicial with analgesics. Give good analgesics. Do not sedate. Try to find the middle ground. Then, right, can an IC tube be clamped? That's the important question. When we were medical students, back then, we were advised always clamp when patient is smooth. There is a point in that, but now the guidelines and recommendation manage try to minimize clamping. Yes, and try to keep the chest drainage bottle below the chest level. That is adequate. Of course, yes. If you are suspecting, there can be commotions during patient transport, patient changing. It is okay to clamp, but make sure it is done under supervision, and as soon as the risk is gone, release the clamps. It can be dangerous, especially in a case of a pneumothorax, where now the lung, you have put the tube, lung has opened. If there is any injury or air leak, it has now opened, and patient can go into tension. So be very careful. And for a take-home message, if you are not sure, if the tube is bubbling, do not clean. The next question, very commonly asked. Large effusion, large collection coming out of the tube. What can I do? I think Dr. Dilip to answer this. Problem we are having is re-expansion pulmonary edema when you remove large volume out. By the guiders, now Western guidelines says 1,500, but our body volume is, our patient body volume is pretty low, so 1,000 is the safe one. You drain 1,000 or 1,500, clamp it at that moment and get a control release. How early? 200 to 300 would be. Now that is in a case of a effusion, large effusion. What if it's a traumatic hemothorax? Now, fortunately, we don't get much traumatic hemothorax in NHRT, but if you are working and you have a polytrauma patient and you put an IC tube, the drainage management is a bit different. Now, like ATLS or recommended guidelines says 1,500 at the initial stage or more than 500 in 3 consecutive hours is of concern, and the patient may need opening. 1,500 initially by the time you put the tube, or 3 consecutive hours more than 500. Patient will need opening. However, in Sri Lanka, although there's no trauma surgeons go for much less volumes. Even 300 sometimes is in our workshops, 300 more than 3 hours. There's a patient might need an opening and a surgical. We will discuss, I mean, expert opinion in the panel discussion. So, ICU is not swinging. What to do? There can be 2 possibilities. One thing, the lung is fully expanded. Another thing is there's an obstruction. So how to differentiate this? Again, your basics. Talk to the patient. If the patient is well, it's tolerating, there's no ARE, but tube is not swinging. Yeah, it may be equal. Go for a chest X-ray. Assess the chest expansion. So if you are thinking radiological and clinical, lung is expanded, patient is well, maybe you can remove the tube. The question of the tube is completed, so you can remove the tube. In case if the question is relevant. The other one is if there is an obstruction. Tubes can get obstructed. Again, assess clinical. Patient not well recovered, its lung is not expanded. So what to do? You can do irrigation. Different techniques have used. Some use bladder syringes, 50 cc, clamp distally, and suck it out. And milking. Now, milking is a contra. Have anyone of you done milking? Yeah, milking there's a special size. Yeah, milking is done by a special equipment that's in the theater. Theater ke thiyena item. Theater denne. So there's a gadget. However, milking, there is controversy among clinicians. There's no actual guidelines that recommend milking, nor that contraindicates. Mainly that depends on local hospital guidelines. One guideline I find was American pulmonologist guidelines. They say only if a very expert is there, milking can be tried. Otherwise, in a non-expert hand, that can be very dangerous, very cumbersome for the patient and the procedure as well. So, if you can't get the obstruction out, but still the tube is indicated, I think we should go for another tube, possibly on the new site. Right, the next question. Patient is having surgical emphysema. I don't know whether in medical wards you get this thing after tubes, but happens in surgical wards after patient. Okay, assess the patient clinical. Sometimes this surgical emphysema can be very threatening. His airways can be obstructed. Huge tension-like thing in the neck, almost obstructing the airway. Sometimes it can be mild. Just again, check the patient, see how he's doing. Check the tube side. Sometimes the tube can come out. Sometimes the eyes are open. Sometimes the suture has come off. Go for a chest X. If the tube needs repositioning, simple repositioning can help. And there are some conservative managements you can do. You can give oxygen therapy. It helps in reabsorbing the leak gas. We can give physiotherapy. Please encourage the patient to walk and negative pressure suction. If the surgical emphysema is very tense, we might have to go for surgical drainage. Some put parallel skin incisions. We usually go for a subcutaneous tube. And if it is persistent, sometimes we need surgical correction. Before surgical correction, always good to go for extra imaging. Ideally, a contrast enhanced CT, if not at least a HRCT or an NCT. Right, suction. 3 questions. Suction, yes or no? What suction? Is it high pressure or low pressure? Continuous or intermediate? Now, suction is not always indicated. If there's a large pneumothorax, this is again BTS guidelines. It can help in evacuating the air. Encourage the lung expansion. Against post-surgical patients, where we had done lobectomies, sometimes pleurectomies and even decortications, when we find the lung is not adequately expanding, we might think of negative pressure. Again, it's selected patients depending on the expert opinion. Again, low pressure suction is the recommended one. High pressure suctions are not recommended. And continuous suction for 24 hours to 48 hours, continuous suction is found much superior than intermittent suction. If you are putting suctions, be careful about the apparatus. We have all suctions are not freely available. Always these tubes conduct our physics tubes conducted the pressure differently. So always, if you are the one who is putting, just test it with, I think sir will explain that. So the commonest question, lung is not expanding. Again, this is the patient clinical. What? Previous scenarios always will apply. See the surgical side. Tube has come out, eye is out, surgical knot has loose. Simply corrected things. Again, encourage the patient to get out. And mobilizing, get physiotherapy, breathing exercises, and suction. Sometimes it can be due to this lung not expanding, it can be due to mucus plugs. So non-expanding lung, especially a expanded lung in surgery, we find right after post-operative day 1 collapse, we go for flexible bronchoscopy to see whether it's suck out and clear there. So despite that, if it is not working, we again further imaging and surgery would be obvious. And again, just to deviate a bit, I said mobilization. I mean, Handagala sir says this very frequently. People who do not mobilize before a procedure will never mobilize when you put them to a surgical procedure stress. So, always patients in your ward who these are respiratory patients, always ask them to mobilize. Encourage them to walk around despite getting back into procedure or not, because those patients who mobilize before procedures, they do well. Very easy to get them out of the bed compared to one who is bedridden, not bedridden, in the bed clumsily, we put an IC tube and ask him to walk. That is not going to work. So always ask your patient to have a walk, get mobilized. Another thing, continuous bubbling. This can be due to simple surgical site problems, ARLE, or again tube damage, or some damage to the lung parenchyma. Again, we go to the first thing, assess the patient clinically. See the surgical site. I'm repeating myself, but has the eye come out? Has the incision open? Tube is in the correct place. Dr. Dilip mentioned a very important thing. Always the site of the skin level of the tube should be documented. So whenever you find a problem, very safe thing to say, if you are not the person who put the tube, is go back to the surgical note and see the skin level. Skin level, there is a discrepancy. That can be the problem. So if not surgical site is safe, then you can see for the tube obstruction. Tube damage. What we can do is we can put serial clamping of the tube coming from the chest side, clamping, and at the moment you clamp the damaged side, the bubbling is stopped. So if it's on the tube side, you can remove the tube. If it is on the drainage side, you can remove the drainage. It's in the drainage. Still not working. You will need further imaging or surgical. Right. Again, when to remove. Assess the patient clinically. Again, I'm repeating myself. The indication of the why we put the tube should be correct. This one. Or it cannot be correct. That's another. Assess radiologically, get a chest X-ray. Pneumothorax, the patient is lung is expanded, or if there's a collection pneumothorax or hydrothorax or whatever, lung resolution has occurred. In that case, don't be afraid to remove a tube. In any case, sterile procedure, it's a very we think that it is putting the tube is the painful part, but removing tube is as well as uncomfortable. It's a comfortable procedure. So give analgesics. Now, traditionally it was believed it should be removed in end expiration, because the negative pressure, the moment you remove the tube, patient will gush into the next phase of the breathing cycle. So it would be inspiration and lung is expanded, so there will be no residual pneumothorax. That was the theory behind end expiration removal. So I personally remove end expiration beyond the safe. I think we'll have a different opinion. We'll discuss about that. But there are articles, latest articles saying that end expiration removal versus end inspiration removal. There is no difference between residual pneumothorax. But make sure you stick into one and with a swift movement remove it. Again, as I said previously, get all the equipment done, clean it, give some analgesics, remove the tube, remove the dressing and the sutures, and with a swift movement, remove it in either in inspiration or in expiration. Now, in NHRD, we as a practice, we put anchor it not as well as a skin suture, where you will find it, we tie it. So it could be ARC. Sometimes in general surgical practices, they put a single anchoring stitch. Again, a recommended one, we can't argue practice. But as Dilip said, if you make a oblique part to the pleural cavity, that oblique part will close over the rib, so there will be no space. If it is a single one, single knot, just put tight packing. If there is a knot there, you can tie it. So that's it. I hope I have answered some questions. I think I will hand over to the expert for the discussion. Thank you very much.
අපි ඩිලක්ස් කරන්න delete people වලින් පටන් ගන්න. දැන් usually අන්තිම වාක්‍යය මම කියන්නේ you have to always කියන වචනේ පාවිච්චි කරන්න බෑ සමහර තැන් වල. මොකද අපි indication එක සමහරවිට ඉවර වෙන්නේ. For example, we have to consider different settings. like you want local gen non handle. So some patients, like pediatric patient, you may have to give CA to put a tube in. But he may be putting a tube to the operate color. The corona patient somewhat unexpected during anesthesia, but if he develops a new color during operation. So we do lung operations by giving oxygen only to one single lung ventilation. Even in pneumothorax house, suddenly betadine clean and who puts the tube? So I personally have put my most will know down it should not be delegated to the most junior one, or not the one core person always. Most experienced one should do the tube. Our patients say breathing after patient letter, back party if you have to put the tube, swiftly down that has to be done by expert. Don't delegate to the on-call doctor, ultimate doctor, you have to do intern to them. If you are a master, you should put the tube. So I have put tubes in different times in my wards to save lives. So if I feel that my juniors may, make a auntie like to avoid complications, because complications mama manage handle is I put personally, right? So someone sure enough, someone sure enough can delegate to seniors. You can't mistake, right? Usually we don't remove even if the lung is expanded in ICU ventilated patients because you have to wait till patient is at least spontaneous breathing. Those keep track of things. On the trachea mask hanging on a positive person at any moment their lungs might burst and giving a pneumothorax you require another tube. So I am very hesitant to remove tubes from ventilated patient unless patient is in the spontaneous. Tips pregnant patients are pregnant like a coma, but diaphragm is up. We have to consider elevated diaphragm, so we have to make it a higher percentage. Preferably mass. Yeah, that's only for pneumothorax. And if you can clamp at least 12 hours, 24 hours. Some patients like swing. So 1 or 2 bubbles might come. Bubbles bubble in some it may be just due to the space. Better work clamping at least for 12 hours and repeat X-ray and see whether the lung drops more than that. Even nothing, but Galloway, I don't discharge him, keep another 24 or 48 hours just to observe. පුදා අපිට 100% ලං තිබිලා ගලවන්න කිව්වොත් ඔක්කොම ලංකාවේ මේක ටික මෙතන තියන් ඉන්න දෙන්නේ ගෙවල යවන්න හම්බෙන්නේ. So we have to accept certain degree of lung expansion. If it's not dropping, we can remove the tube.
Structural decay, for example, you said that.
Yeah, and the non-expanding lung, what was the bronchoscopic account? Even a bronchoscopic account, one cause for lung expansion, non-expansion, maybe bronchial obstruction. So mucus plug gets in the lung, and meeting mal ek hetuවක් තමයි TC barrel roman මම හිතන්නේ ඒක ඇත්තටම ඉන්නේ. The first thing is, you know, බටේ මේ අදම දුවන පාර මේ නැත්තම් බටේ crack වෙන්න පුළුවන්. these are just physical things නේ. ගැලවෙන්න පුළුවන්, වැදෙන්න පුළුවන්. So those වෙන්නේ රෝහිත ඉස්සරහට wait කරා මොකද මම ඉතින් ආපහු wait කරන්න පුළුවන්. You know, කරනවා. ඒක තියෙනවා cardiac ports වල ඒගොල්ලෝ wait කරනවා. cardiac unit. Yeah, which might come a pressure difference might cause, you know, barrel draw. It's like a pull.
If there's obstruction, you can flush it.
Yeah, flush can pull. Yeah, but I do
That is the advantage in, like, you know, tilting the tube. You have a three-way tap.
Three-way tap.
You can easily
connect it. I can pull out. The market can be connected with the battery. What I do is I put a clamp in my patient. Patient, I put a clamp here and disconnect from the connector. Messaging somehow make government back patient. So what I do is I shut the tube from here. Because all local emotional Mahendra Bhatta and you be masters of tubes, Mahendra flush current. And the other thing I got to tell you, Ape butter, Galan, Ape medical load, surgical load, you won't believe England or butter Galan in Sea. Yeah. Okay. So they are trained for that. You Galvanica, I think we will have to learn. Deep inspiration, inspiration. But I have personal experience. The muscular people, when you take a deep breath, hold the muscle power we make a huge amount of negative pressure inside. But take a lot to so those patients better to do in deep expiration. Spike gram, who's my movement in yeah, I can say, but usual people, deep inspiration is okay. And why the ICU patient around there, Mamasan, name us. So we have but is someone Achipota, Husman and Arthur, just that. You know, I mean, we can't wait for Ushagar in the Ulang. So we have to do it quickly. I like that's a connected to the Yaga, pressing at the person is done, pressing that time. Occlusive does in that, team, and pressure does in that killer. We come back to this. Plaster Mama, product out making around making elements and after that is indicated, that is indicated, muscle later. Gone away, make it. Within hand away. So what I do is I cut about within and get Hakara to the you make up. You make a up in the handful that is indicated. That is in the Purugarnas, Isilota, and Puro. We must make a guy, ask somebody to unclamp. It has to be a straddle procedure. It must make a 2 and block again. You pick a block, sure, and try to make it down, then disconnect it. You may swim and make a bind first. Can't know never. We have to make block because we connected, but everything connected block. And some tubes come, the way make air in there, some are tubes. Especially one compartment, you to go, but in the mail. Make it a connector. Make up harmony, rain when you are done. Make up the make hyperology, make as you know, may have a plastic button, but about it, fusible, but it a moment post to play into the garden. For pneumothorax patients, I might use, but for drain purpose, I won't put this one, you can make what to need. So the major purpose never can help you to do. May I but no so I don't do make a dance and monk currently tube bag maru make carry take up decay mena. These are something to say. Make tube bag take up connect make button take up. So everyone make tube bag का article but एक कपड़ा लेता. So run बड़वा के दाम ने पा वो pneumothorax so he can find mass. लेकिन हम कंगारा ये block कर. It was make up. जैसा लिखो रहता. अब make क्या कपड़ा ला. We made butter within Kapan or blue waking allow line after. Make a Mahema butter, සමහරවිට මේක අත්තර ගලවන්න බෑ. it's been glue. මේක රැකන්න glue කරලා තියෙනවා. කඩාගෙන නැත්තත් මේක ඇදෙන්නේ නැහැ. බටේ ඇදෙනවා මිසක් මේක ගලවන්න බෑ. එහෙමනම් කරන්නේ දැන් මම බටේ කපන්නේ මේ හැරෙන්නේ. මේක අපලන්නේ මේක දාන්නේ ෆ්ලෂ් කරන්නේ. ඊට පස්සේ මේක ගලව ගන්න කාරණේ මම නම්බෙලම් බ්‍රේක් එක කරලා මේක කපන්නේ. මේක ස්ටික් කරනවා වෙන්ටිලේටර්. මම එකක් පිට ලොක්කට දාලා මේක අර මොස්කිටෝ ගින් වගේ මාරුවෙන් ඇදලා එළියට දානවා. ඉතින් අඟල් හතරේ බට කාලේ විසික් කරලා මම බලන්නේ එළියට ගත්ත බට කාලේ මේක ආපහු ගිහින් that's the practical way to do that. That's how I want that video going on. මම කරන්නේ කොහොමද? because with my experience මේවා ගලව ඉස්තිරට මේ බටලා data ගෙන දාන උන් කියනවා මෙහෙ ඇදුනොත් so best thing not to disturb the patient මේ කරලා මේක local මුකුත් දෙන්න ඕනේ නැහැ උන් කරන්නේ කියලා.
usually a punch stroke seal.
So සීලා but මම නම් අර ටෙලග්‍රෑම් එකක් දානවා in 5 minutes එක මේ මම ක්ලාස් එකකට දාන්න ටික. ඒ ගානකොට අපි දැන් ටීප් එක උනත් මේක අන්නේ බටේ කිව්වම fitness එකක් තියෙනවනේ. I want inject like this but sample එක ගන්න ඕන නම් you go in an angle. එතකොට මේක fast track වල වැඩ කරන නිසා ඒක උඩට master දානවා මේක seal වෙනවා. same principle as how you put a tube in බටේ අර ඇදෙන්න දානවා වගේ. එතකොට ඇදෙන්න ගන්න. අපි fluid sample එකක් ගන්න ඕන නම් fluid sample ගන්න කට්ටිය දන්නවනේ නේද? ළමයි මේක මාර්කර් මේ අපි මෙහෙම පොඩි ලූප් එකක් හදලා ඉඳලා patient ගෙන් fluid එකතු වෙන්න දෙන්න. රිසල්ට් දුන්නාම පස්සේ ඊට පස්සේ pain එක දැනෙන්නේ. කල්චර් වලට ගන්නවා නම් you can't use medicine or spray. කල්චර් වලට ගන්නවා නම් තේලයි. ඒක ඊට පස්සේ clean කරලා sterile වතුර වලින් හරි saline වලින් clean කරලා ගන්න කල්චර් වලට ගන්නවා. ඒක cytology purpose ප්‍රශ්නයක් නෑ මොකද clean ගත්තා. එහෙම ඉක්මෙන් දැනලා ඒක අර මම කිව්ව විදිහට ඇදේට දාලා ගන්න ඩිරෙක්ට් ගන්න නැති. ඇදේට ගහලා ප්‍රයිවට් සෙක්ටර් එකේ නම් මම ටිකටම පැච් එකක් දානවා. සිදුරු කරපුවායි. මේ දේව කරනවා නම් ටැම්ප් එකක් දාලා කරන්නේ just to be on safe side. Whatever you do better tell the patient what you are going to do. So it is private side සාමාන්‍ය shooting. වචනය ගන්න ඒකට කියන්න ඕන මොකද කරන්නේ. ලෝක මේ ගලවනකොට මම නම් ලෝකල් දීලා කරන්නේ මම දන්නවා දරා සර්ජන්ස් who don't give local පොඩි ළමයින්ට සමහරට ක්ලෝරෝ ටෙක්ට්‍රේට් හරි මොනවද දීලා ගලවන්නේ පොඩි බබා දුක් වයින මම ලෝකල් ටිකක් ගන්නකොට I don't like hurting myself මගේ බටයක් දාලා තිබ්බොත් ඒ ප්‍රින්සිපල් එකෙන් මම නම් ලෝකල් එක දීලා ගලවන්නේ මොකද මේ විදෙන්නේ බටේ ගලවනකොට නෙමෙයි දැන් ස්කින් එකේ අපි දැන් මේක ස්කින් එකට මේ කැන්සර් කරන්නේ වටේ මේ ඇතුළේ ට්‍රැක් එකට හැදිලා තියෙනවා ටෙස්ට් එකට යනවා නමුත් මේ ගැටේ ගන්නකොට අර කිචි ගැටේ තද වෙන එකෙන් තමයි ලෙඩ විදෙන්නේ නැහැ ස්කින් එක don't think it's a tube local ටිකක් දුන්නා local ගන්නකොට ප්‍රෙෂර් මුලින් ගන්න ඉන්ජෙක්ෂන් එකකින් විදෙන එකද වාට රිසන්ට පුළුවන් බටේ ගලවන එකද පුළුවන් ගොඩක් ලෙඩ 90% of the patient විදිහේ ડોක්ටර් මොනවාර දෙන්න කියලා කියනවා. but තවත් ගොඩක් මේ අප්සෙට් නම් sedation මෙඩිසන් ටිකක් හරි මොනවද කියලා කරාට කම්ප්ලීට් sensitive results අවුරුදු 10 11 ටීම් විදිහට හරි අපිට කරනවා නම් පොඩ්ඩක් කොහොමද ෂොට් එකක් දීලා කරන්න කරලා
What is the cost of this?
මේ ටියුබ් එක නම් මම දුන්නා කරනවා කියන්නේ මොකද? මොකද දෙයක් ටිකක් අපිට 5000 දෙන්නේ. දැන් අපේ නම් මේව මම කරලා 4-5 මයික්‍රෝවල්ටි කවුරුත් නැහැ නේද? What is your recommendation to remove this tumor? How frequent we should be starting? What is our emotional system and our මේක ගොඩාක් මකිස් කප් එකේ තුන ඇසෙන්ඩින් ඉන්ෆෙක්ෂන් එකක් වෙන්න පුළුවන් නිසා better to remove මොකද? ડોක්ටර් වොටර් ෆීල් එකක් තිබුණා අපිට වෙන්න පුළුවන් නිසා. But 3-4 days we can sleep. But එකම දෙයක සමාන වෝටර් රවුන්ඩ් එකට කලින් මේ දවස් 5 ඉදා උදේ වෝටර් රවුන්ඩ් එකට කලින් නම් අපිට අපි වෝටර් රවුන්ඩ් එක ඩිසයිඩ් කළොත් අර ෆ්‍රෙෂ් බොටල් එක දුකේ බෑ ඉතින් ෆික් කරනවා. ගලව. We can't treat patients like that. එහෙම coordination නැත්නම් නෑ. But ඒක ගලවයි කියලා හිතනවා නම් that කියන්න පුළුවන් මොකද මිසිලා ඒක ඩිසයිඩ් කරන්නේ උදේ ඒගොල්ලන් උදේ පාන්දර 6 නයිට් රවුන්ඩ් එකේ මිස්ලා ඒක ඩිසයිඩ් කරන්නේ. එතකොට උදේ වෙනකොට ඒක චේන්ජ් කරලා ඉවරයි. Food drop by the time you sample water drop. ඒක කරාවින බෝතලයක් අපිට දානවා තමයි උදේ ගැලවෙන්නේ.
So sending a tube will make 24,000, so it is more cost effective.
Yeah, this very cost effective. But
you can control and after removal also you don't have to shoot it.
yeah,
Sending
එක ඒක සුචි කන්ට්‍රෝල් නේ. But it's not
Yeah.
professional available. Special design නැත්නම් මොනේ. Sending us will come now. And make it
we have a few tube at the
no
moment.
no investigate no stop back in. We will get it. Sending
And I think that, as you said, like medical board staff should learn how to remove the tube.
ඒක ගලවනලාට ඕගොල්ලෝ පොලිටි එන්න මාසයක් දෙකක් කවුරුහරි එදාට
It's a very simple thing in
එන්න
very.
සර්ජරි ලෝඩ් එකේ බලාගන්න. බලාගෙන ගලවන්න දුකේ. පස්සේ දාන්නත් උරුදේ. it's a more because Some of our doctors are leaving or go emergency medicine. Namma na dialogue ko private sector game OPD වැඩ කරන doctors පණ කඩාගෙන යනවා ඔක බලන්න.
Hello, sir. Excuse me.
Yes, please, yeah.
Sir, this is Sachini.
Yeah, yeah.
Sir, thank you so much for organizing this, and thank you to the two senior registrars who did the lectures. It was all very well conducted. Thank you. Sir, like you said, not just the removal, I think all respiratory trainees need to train in IC tube insertion. So anyway, medical thoracoscopies are performed. So this is just, there's a very little difference between the two procedures, and cell digger chest drains, they are available on and off. So I think insertion of IC tubes is it should be a mandatory part of trainees as respiratory physicians. And this I would like to highlight particularly as when I was in Kandy as a consultant for a short time after my foreign training, we had to send for IC tube insertion to the general surgical team. And it's usually done by an inexperienced registrar in the middle of the night under no supervision. Very badly placed, and we had to redo the procedure in the morning in the ward. So, I think all respiratory trainees should train in insertion of IC tubes. And my request to you, sir, is if you can do like a step-by-step video of a procedure and share it among us, it will be very good for everyone. And also, if you can. As soon as these general surgical trainees go into their training, I think this is at least historically, this is something any MBBS doctor should be able to do because it's a life-saving procedure. So in your induction training for surgical registrars, if you can have a training for this, I think it will be life-saving all around. Thank you, sir.
Thank you, Sachin. And for your comments as well as suggestions. Yeah, in fact, yeah, the surgical registrars, of course, are given training because they have to do accent service appointments also. No? They put a lot of queue and a few online questions.
Yeah.
Any other questions? Yeah.
So there are two online questions. One is patient with neuromuscular disorders who are on NIV as complication can develop pneumothorax. And when do we remove IC tube in this patient? And if the patient is not improving, what is the next step?
Yeah,
the patient will be on NIV.
Yeah.
Yeah.
Yeah. There's a question whether the patient who are on NIV for neuromuscular disorders, when to remove the IC tube. Yeah, if the
developing pneumothorax and
that is removal again, the whole same guidelines will go, right? The lung should be expanded. There should not be bubbling, continuous bubbling. And
Actually, it is individualized.
yeah, it should be individualized to the patient. So one thing that we recently, found was to, if you available to put pleural veins. Or pleural vein bilateral pneumothorax, 18-year-old girl miliary TB, bilateral pneumothorax with bilateral IC tube. We managed to find freely he gave two pleural veins, went dala. Eventually we removed the IC tube. Went take a function that is one option. The other option
What
is
she asking is like, when there's a pneumothorax, there's a contraindication for NIV as well.
no, I mean that we have to clinically judge, the benefit of NIV versus pneumotherapy.
So treated pneumothorax, you can put NIV continuously.
Yeah, of course, yeah. And then problems start when if we develop the surgical emphysema on top of that, if the pneumothorax worsens, then we may have to do a HRCT and see whether there is a ruptured bulla on top of the underlying lung condition. So a lot of things come on the line if it's not settled. But settled line on because NIV, how much of PEEP will incur the NIV? Is just like normal breathing, or will there be any PEEP on that?
There will be pressure support, like PEEP, about pressure support. It depends, like it can go up to 14 to 15.
The last time there was that lecture recently, that what is that tricular that is tricular gray. That's another tricular. is like a jet ventilator, but high flow oxygen. High flow oxygen therapy. High flow oxygen therapy.
High flow.
Yeah, 30 liters and everybody 40, 50, higher the
45, 60.
higher the flow, so much of pressure incurred on the alveolar level. So that's the amount to intubate කරු patient කෙනෙක්ට සමානස ඒක වැඩි feedback දෙන්න පුළුවන් අර flow එක. So need to be careful, even NIV incurs some amount of feed. So that may aggravate the pneumothorax condition if it's a big leak. අනිත් එක තමයි මෙලා මේ කිව්ව එක mobilize කරන්න කිව්ව එක again ICU patient කෙනෙක් නම් post operated and mobilize කරන්න බෑ. But even in general hospital they do a tube එක දාලා ලෙඩ ඇඳලා කරලා catheter එකකුත් දාලා එයාට ඊළඟ දවසේ inoxaparin පටන් ගන්නවා. You know, which is bad way. හොඳට ඇවිදන් හිටිය ලෙඩ simple pneumothorax or simple effusion, which should not be done.
If pneumothorax is not improving with initial IC tube, is there any evidence for better outcome with large size tube reinsertion?
Yeah, first we need to check whether the tube is working. If it's for pneumothorax, the same tube and added bronchoscopy to see whether the airway is open. We can apply low suction and see. Low suction then better go for a CT rather than replacing the tube. But block tube tie, non-functional tube tie for long standing tubes, what it leak in water, we might go for a new tube, and after putting the new tube only we'll be removing the existing tube.
Insisted
Cavity IC tube will there be swinging? Like once
Yeah, that will depend on the how bad the lung coating is. Lung if there is a lot of fibrous tissue on the lung, it may not swing. Concrete swing guide color important.
Hello, sir. This is Sugisha. Can you hear me?
Sugish, can. You are from England.
Yes. I'm joining from UK. Just
Okay.
to answer Chanutri's question about, from my experience, if someone is having a pneumothorax while the patient is on NIV, what we can do is, if the pneumothorax starts, if the bubble stops bubbling, that means the pneumothorax might have settled. So at that time, what we can do is, although this is not recommended, most of the time what we do is we clamp and see whether that will settle. We clamp and keep for 1 or 2 days and repeat the chest x-ray whether this re-expands with NIV.
Right.
If nothing happens, you can take it out.
Right.
And the other thing is, if the patient is tolerating, if it is a mild disease, we can give an interval of NIV, given a period of interval without NIV 1 or 2 days. That will also give an interval to settle the problem temporarily. Then at that point you can try it.
Right.
that can be easily done with these smaller tubes,
Yeah, smaller tubes.
Cylindrical tubes.
Yeah. Thank you, Sugisha. That makes sense.
Yes.
Either come down on your NIV side, or
Yeah.
either we can, if there is no bubbling, less swing on the images you see expanded lung, we can plan the lung and plan the tube and see whether it aggravates. I mean high flow oxygen. Sugisha, you keep online, right? How the high flow oxygen affect pneumothorax, simple pneumothorax. So what is the principle? SRTS part? High flow oxygen, we don't put a tube, mukut karne, needle spread karne, simple pneumothorax. You can treat with high flow oxygen. Say 6 to 10 liters. And SR oxygen then what is the principle behind? वो संभाल लेते हैं दोनों यूके वाला सिंपल pneumothorax sometimes their community service is good they to ගෙදර යවනවා මෙහෙම admit කරන්න එයාට GP setting එකේ x-ray ගන්න පුළුවන් නම් ලෙඩා daily හෝ every other day x-ray ගන්නවා ගෙදර යවනවා so admitted patient ලට simple pneumothorax නම් යන්නේ respiratory side එකට side එකට traumatic නම් යන්නේ surgical side but even admitted they might observe කරනකොට ඒගොල්ලෝ මුකුත් නොකර ඉන්නේ but pain එක දෙනවා pain killers දීලා they give high flow oxygen what is the rationale Joshua? Okay, that's the principle is, nitrogen wash out here. When you give oxygen.
The more, so that's the rationale. As you correctly highlighted, if you give high, it will increase the absorption of the pneumothorax at a higher rate.
So why we are worried about pneumothorax in air travel? Pump can. But is respiratory isn't anything here. What is the problem is, air travel and pneumonia. Because pneumonia is a line with the aircraft taking was person. We have to learn the respiratory what then happy. But what a patient would take well out them surgery actor. The Riastari proving how the you have to give flight clearance. What is the rationale? We have to improve our update ourselves. Like aircraft taking pneumothorax process. What can but negative pressure. Negative pressure needs. Gravitational effect is aircraft gravity component. So gravity low. Gravity low and nutrient. Gravity is the partial pressure. Partial oxygen name atmospheric pressure level. So we plane ground level. Plane can this one the make aircraft pressurized up to about 8,000 level. Aircraft pressure make pressure temperature. Make a harmony at the level aircraft pressurized. I may respond the plane colony. Respond Mammy, other topics are interesting in the again. Pressure level like a thin men. Make a fuel consumption on there, make a movement, propel around it, get pressure so they can save lot on fuel. I think is speed that do not make a maintain Columbia, Frankfurt, Germany, Yande, make a fuel consumption card, look at how cannot buy. So in the summer, may aircraft design color would right? How I got local gold round is among the ethanol effect. I'll hang you ground in the surface. Right? I'm really speaking, the aerial height, height tech aircraft destination if you go very high. Good up here. Local the Caterpillar environment surface is the anti 40 feet take up here, but never high tech are fuel saving. May actually aircraft take a pressure maintain counter or taking young bypass energy of carry. And may fuselage take a pressurized current, jump is make a carry. For that reason, they pressurize only up to about 8,000 feet, 8,000 or 10,000. Military hemat now, so military Fatima than how they are see those who are trained in these things, their physical abilities are more, their systems are more. They were somewhat pressurized no normal guideline is pressurized never and back. Civilian never home and back. Military because they carry more fit people. Energy through me level with pressurized. Make a normal atmosphere pressure, but mother can take a kilopascal. No, again, 180 MPa, 180 MPa, it is a kilopascal. May have it ever Samani, Hasu. But take out my maintenance, make Spanda, have it again, make other little doing. So, what does it yam? This is protected and media and voice slow with the mother. Pressure is inversely proportional to the volume. Again, pressure the new out, make away. Better alone is a volume effect again. So, what are media shift with normal simple pneumothorax on the ground level will cause a massive, tension pneumothorax. Here recently in the summer when pneumothorax has led to full lung expansion, it's certainly be master of then 7 to 10 days normal lung Clipchamp okay currently flight. Isargala 2 to 3 months of then 1 week if you sector, even butter sector export like even there should be a person who can put a tube in cabin. Medical circumstance even but practically more than they are making rolling immediately forget no gravity. So they are switch level normal login they can see better process current. But if they go out or space suit at the elevator down on a suit to get very well. දැන් කතා කරන්න වෙලා මොකද LED කැම්පස් මේ බොඩි කූලින් නෑ බොඩි එක කූල් කරන්න වෙනම වෙනවා බොඩි උලන්න තියෙන කූලින් වලට වෙනම ඕනේ බ්‍රීතිං වලට වෙනම මේ සූට් එක ඇතුලේ තියෙන කාබන් ඩයොක්සයිඩ් වලින් ඔක්සිජන් හදන ගැලි තියෙනවා ඔය කියන්න මේ තවම කස්තින බඩ
Always indicated. On the BTS guideline, they have taken like pH between less than 7.2, always indicate right to, but around 7.2 to 7.39, then you may say complicated flow regulation, also like you have to put ICT.
Yeah, antibiotic physiotherapy and repeated pleural aspiration will be polar managed plus pigtail length.
Yes, they have changed, but I don't think our.
Okay, Nandan, we have to consider with the TB efficiency level. TB level, TB we are still resistant to put tubes. TB efficiency better to start ATP if the patient not breathless. If you are no evidence of secondary bacterial infection, better to go on with TB and see the response. But respiratory distress now requirement
It all depends.
Depends. It's individual clinical.
Thank you so much, all the speakers.
Sukisha, are you still there?
Sukisha. So I'm very happy that now we have become to an international level from overseas also.
So I'm here. Hello, so I'm here.
Sukisha, we are going to wind up. You got any inputs?
No, can I add something about the size of the tube and empyema?
Yes, please. Yeah.
So I think the trial is missed. The size of the tube does not matter when it comes to empyema, but we are dealing mostly with the Seldinger tubes. So size 12 or size 18 has not shown much of difference. However, what we do in our trust is whenever there is a, especially for a tube for empyema, these patients are given regular flushers. That avoids a lot of problems, especially the tube blockade. That is something I want to let you know from my experience.
You have a small tube, you have like
Right.
that control.
You get the point. You put a smaller tube, but you flush regularly. You don't wait.
Yes. No. We anyway we will be flushing it regularly.
Right.
So thank you so much.
6 hourly or 8 hourly. 8 hourly or 6 hourly.
Right. Thanks to be here.
Thank you. So thank you all the speakers and expert panel, Welisara and Dr. Neil. I think this time like a lot of people from the other hospitals also joining online. So all interesting topic, not only the academic, other we learned about aircraft and all. So thank you so much to everyone. And I would like to thank the speaker sponsors, Lena Pharmaceuticals. And you can for sponsoring the event today, and you can take your lunch outside. Thank you so much.